Do you find the telehealth policy landscape in the United States confusing and difficult to understand? Especially in recent months, as the nation navigates the COVID-19 public health emergency? We are finding that the policies are now changing at such a fast pace that it has become very hard to keep up and make sense of exactly what the laws and policies are within each state and federally. So, how is telehealth policy structured in the United States, and why is it so difficult to navigate? As you will soon see, telehealth policy is like an onion. There are a lot of different layers to it. It can be confusing if you don't break it down and dissect it piece by piece. The first thing to be aware of is that the majority of telehealth policy in the United States is centered around reimbursement, or payment, to healthcare providers from insurance companies to compensate them for healthcare services. Reimbursement policy is critical in the United States because if providers don't get paid for the services they are providing via telehealth, they will not utilize it. It has also historically been cited as the #1 barrier to telehealth adoption in the US because the rules around it are so cumbersome. There are other policy areas, such as cross-state licensure, establishing the provider-patient relationship, data privacy, and malpractice. But for this video, let's just focus on the reimbursement policy area. There are two groups of telehealth policy in the United States: federal policies and state policies. The first group is federal policies, which when talking about payment falls under Medicare policy. Medicare is the U.S. federal government's insurance program for people over 65 and certain younger people with disabilities. These federal Medicare policies are important because they govern the largest payer in the country, and policies that impact Medicare can sometimes be replicated on the state level. The second group is state policies, and this is where things get tricky. Because the United States has 50 different states, plus the District of Columbia, and several territories, each with their own unique policies, it creates a patchwork quilt landscape that can cause confusion and can be difficult to navigate. To make things even more complex, within each state there are two primary payers: Medicaid programs, which are state-federal partnerships that provide healthcare coverage to low-income families or individuals, and then there is the private insurance market, which covers most everybody that does not fall into the Medicaid and Medicare buckets. And you've probably guessed it by now. Different policies apply to each type of payer. Are you with me? I told you it can get confusing. When you examine a specific reimbursement policy, there are typically 4 elements involved in the structure of that policy. First, who was the provider providing the service? Second, what was the service provided? Third, where was the patient located? Last, how was the service delivered? That doesn't sound so bad, right? Now, let's add COVID-19 pandemic into the mix. During the COVID-19 pandemic, there have been many changes in the answers to these 4 questions. Various inclusions have been implemented to ensure the American population is better supported and to mitigate the effects of the COVID-19 pandemic on essential healthcare services. Most of the COVID-19 changes have occurred through waivers and executive orders. This means they are temporary and must either have expiration dates or are subject to end when the COVID-19 emergency is declared to be over, and nobody seems to know when that will be. That means that the answers to our 4 key questions will most likely be different depending what type of organization is paying for the service. Let's break it down by the 4 elements. First up is federal policy, which means we are talking about Medicare policy. Medicare places restrictions around each policy area listed in our 4 key questions. First, we'll consider who the provider type. Under permanent policy, Medicare restricts reimbursement to only 8 distinct provider types, including physicians and nurse practitioners, among others. Under COVID-19 policy, all eligible healthcare professionals eligible to bill Medicare can provide services. Next, we'll look at what? The type of service delivered. Under permanent policy, Medicare restricts reimbursement to only approximately 100 different types of services, each associated with a different code, when there are thousands of potential codes that could be reimbursed. Under COVID-19 policy, Eligible services for telehealth reimbursement was expanded to include 240 service codes. Next, we determine the where, which is the patient location. Under permanent policy, Medicare requires a patient to be located in a rural area and in a specific type of medical facility. They are not allowed to be in their homes, although there are a few exceptions. Under COVID-19 policy, services can be delivered to patients in their homes and in any geographic area. Finally, we need to consider the how. What is the service delivery method? Under permanent policy, services must be delivered via live video telehealth. Other forms of service delivery, such as asynchronous store and forward, only qualify for reimbursement if it is in Hawaii or Alaska. Under COVID-19 policy, services can be delivered via live video, and some can also be delivered via the telephone. Now, are you ready for things to get even more complex? Medicare considers telehealth services to exclusively encompass only services that could substitute for an in-person service that they already reimburse for. Other types of services that can be delivered using telehealth technologies and have no in-person equivalent are considered to be technology-enabled services and are not subject to all of the restrictions that we just went over. It is important to note that each of these types of services have their own requirements associated with them. Okay, now you're probably wondering how we answer our 4 key questions on the state level. Well, let's first address Medicaid. While it differs from state to state, as mentioned previously, we can speak in generalities. First, we need to look at the service delivery method. As of September 2020, 50 states and DC reimburse for live video, 17 states reimburse for store and forward, and 22 states reimburse for remote patient monitoring. Second, we need to consider the provider type. States vary in the types of providers they allow to provide telehealth delivered services. The most common providers include physicians, nurse practitioners, and psychiatrists. Some states allow other providers such as psychologists, physical and occupational therapists, and even nutritionists. Still, other states allow any provider enrolled with the Medicaid program to provide telehealth delivered services as long as it is within their scope of practice. Next, we determine the type of service delivered. States are split in how they define the services that can be delivered via telehealth. Some copy Medicare with a specific list of certain services that can be provided, while others allow any service to be reimbursed as long as it is medically appropriate. Finally, we determine the patient location. States do not impose the same geographic requirements as Medicare, but many do require the patient to be located in a specific type of medical facility.
Just like Medicare, states expanded their telehealth policies with the onset of COVID-19.
Many are temporarily allowing the telephone to be used to deliver services, the patient to be located at home, and expanded services and providers to be eligible for telehealth reimbursement. Finally, we have private payers to consider. Remember, they are regulated at the state level just like Medicaid, but they have different laws that apply to them. As of September 2020, 43 states and DC have laws in effect that address private payer requirements for providing reimbursement for telehealth delivered services in some way. Not all of these laws require reimbursement, as some of them leave reimbursement up to the terms and conditions of the contract agreed to between the provider and insurance company. Other states may have stricter laws that mandate the payer to provide reimbursement for all services delivered via telehealth, and even at the same rate those services are reimbursed in person. As long as a payer is complying with the requirements of law, they can create their own unique policies within that framework. And the answers to our 4 key questions will therefore vary from payer to payer. Now that you understand the framework for telehealth reimbursement policy, let's take an example. Meet Maria, a 19-year-old college sophomore with a disability. Due to COVID-19, Maria had to return home to stay with her family. Maria needs regular counseling for her anxiety, but she can no longer safely visit her healthcare provider in person and instead will now see her doctor through a telehealth session. Let's answer the 4 critical reimbursement questions for Maria. First, we need to ask who was the payer and who was the provider. Because Maria has a disability, she is covered by Medicare, which means we are talking about federal policy. Because she has anxiety, she is seeing a psychiatrist, which is on the list of Medicare-eligible providers, even without the COVID-19 expansions. Next, we need to determine what type of service was provided. Maria is seeing her psychiatrist for a 30-minute office visit. This is an eligible Medicare telehealth service, even without the COVID-19 expansions. Now, we need to consider where the patient was located. Maria returned home to the suburb where her family lives, but still within the same state as the college. It is not a rural area, and she is accessing the service from her home because she does not want to risk COVID-19 exposure by visiting a healthcare facility. Under normal circumstances, this would make the service ineligible for telehealth reimbursement in Medicare because Maria is not in a rural area and is not in an eligible facility. However, under the COVID-19 temporary expansions, it is currently reimbursable. Finally, we need to determine how the service was delivered. The service was delivered by means of a live video interaction, which means it's eligible for reimbursement. However, once in a while, when the internet is down, Maria needs to call her provider instead of connecting via video. The phone call interaction is only reimbursable under the COVID-19 expansions. Now that you can see what a big difference the COVID-19 expansions have made for Maria, who would not have been able to access her psychiatrist without them? You may now be wondering what will happen to telehealth policy when the emergency ends and all the temporary policy expansions go away. Government authorities are already starting to think about this. For example, the Centers for Medicare and Medicaid Services, CMS, is proposing through their 2021 physician fee schedule to make some of their expansions in the services that are eligible for telehealth reimbursement permanent. However, there is only so much that can be done administratively by CMS. Because a lot of the reimbursement policies are in law, congressional action is needed to change them and avoid a cliff edge effect when the telehealth waivers expire and people are left hanging not knowing what to do. On the state level, some have already taken steps to make the policies permanent, while others are taking more of a wait-and-see approach, extending their telehealth expansions only by a few months at a time. For the time being, we can only speculate as to what the telehealth policy in the United States will look like in a few months. Is your mind blown? And we didn't even get into some of the other areas of telehealth policy, like cross-state licensing and prescribing. As you may already know, the Center for Connected Health Policy is the federally designated National Telehealth Resource Center on policy through funding from the Health Resources and Services Administration. We are here for you. If you have a specific question related to telehealth policy that you need answered, contact CCHP. info@cchpca.org.